have to remember that. Anyway, good morning. Okay, look, let's get through this. It's the last day of the week. We've had fun. This is going to be my part of this lecture today, which is the last 20 minutes, is going to be fun. Vicky's first part of the lecture, the first 2 hours of this today, is going to be intense, really good. I got a chance to preview her slides quickly. They're elegant, they're beautiful, and I think you're going to just learn so much. She put a lot of work into this. Anyway, with that said, you know our scroll bar right there. Look it down there, right there. Contact@perfusioneducation.com. Next. Phone number 832-239-5358. Next. Scroll bar comes up intermittently. I used to say it was there through the entire show, but I was corrected. It's not. But keep an eye on it. It comes up every now and again. So that's that. We have our MediWeb app. You can go on Google Play or iTunes Store or whatever, or App Store and find it. It's a really cool app. There it is. You can use those little things there, the QR codes. Podcast, whatever your favorite podcast listening platform is. Next, our adult ECMO specialist course, training course. Next course is scheduled for June 27th and 28th for the didactic, July 1st and 2nd for the simulation portion of it. To do the full program, you do have to travel here to Houston, but there are programs where we can, or plans where we can take the program to you if that's what something that you wanted. But the didactic only portion is available and approved for Perfusionists. Well, the whole program is, but the didactic only also for Perfusionists, for nurses, for advanced practice, physicians, everybody. And the full program's 40 CEU for perfusion through the ABCP. The didactic only is 20. If you are a member of our Perfusion Education library and channel, it is included in your unlimited plan, because when we say unlimited, we mean unlimited. But if you want to buy it separate, then I believe the cost is going to be for the didactic about $600, somewhere in that range. Mm-hmm. But you can find all that information if you go there and look through all of the selections. Okay. Registration will be live later today. Perfect. Dude, thank you very much. You're also going to probably get an email message. Okay. My dear colleague, good friend, critical care nurse, adult ECMO specialist, educator, coordinator, director. I could give her a million titles, and it just would never be enough. But I consider her somebody who really is, in many ways, a counsel to me. I value her opinion. She's just so incredibly talented and knows so many things. I cannot compliment her enough. And that makes her uncomfortable when I do that. But she'll get over it, okay? She's really somebody I consider very special. And then, look, there's another dear friend of mine, Thomas DeSalvio. Half of what I know about perfusion I learned from him. Comes from the medical center down at Methodist in the big Mecca, the heart, DeBakey Heart and Vascular, like the beginnings of cardiac surgery. Super cool dude, knows a lot of stuff, always does a great job. Thank you both for being here. I'm going to turn it over to you, Vicki, and let you get started. Any questions, you can, of course, put them on the YouTube or the Instagrams or the FaceSpace or whatever it is platform you're watching this thing from. I monitor the YouTube, and Magic monitors the other platforms. And don't forget, if you want to call in, please do not hesitate to call in. That would be super cool if somebody called in live today. Vicki Carlyle, floor is yours.
Did you say space place?
Face place? Face. Yeah.
Wow. Okay.
Is that what it is?
Mm-mm.
FaceTime?
Close. Very close.
MySpace?
No.
Space face.
Space face.
It's the space face. Morning, Thomas.
Hey, good morning, Vicki.
All right. I'll be talking
Morning,
about...
Joe.
I'll be talking today about the regulation of cardiac and vascular function. Strong focus more on the vascular side of things in this lecture. This slide I put in here just to get us started. It's just a beautiful slide. I'm not sure what kind of stain they used, and I wish it really looked like that in the body. What do you think?
Yeah, I mean, I think it's elegant. It's a
It's very
beautiful. I
pretty.
mean, it would almost be a piece of art that you could put on the wall, and it'd be interesting to see how many people would actually know what it was, because there's a lot in there.
Yeah, you can see the lymphatics coming down, everything. It's very, very beautiful. They used an excellent stain on there.
And I think it's so interesting to see how the red blood cells are, because these are real red. This isn't a painting.
No.
This is an
It's a
actual
real
stain,
slide.
right? And you can see how the red blood cells are deforming, likely either from having to squeeze through a small hole or accelerating, because either way they're gonna deform. And just showing, being able to see that is really cool.
Yeah, especially up there. This one actually, it's all ruptured there, maybe? I don't know. Still, very cool slide. All right, so I'm going to start with the peripheral vascular system, which is a component of the circulatory system, and it does include our lymphatic system, with blood vessels being the components of this system. They're responsible for the dynamic transportation of matter and blood products to every cell in the body. So they're not like static pipes. They actually constrict, relax, pulsate, and even proliferate, with the primary function to distribute, exchange, and act as capacitance vessels. They distribute blood from tissue to the organs, exchange gases, nutrients, and waste. And of course, the veins have the big role of capacitance and holding most of our blood volume. It includes everything outside of the heart, so all the blood vessels that exist outside of the heart. And they play an important role, of course, for all of our main organs to do their job as well, such as the kidneys for cleaning, lungs for gas exchange, digestion for absorbing and exchanging the nutrients, and also a very important role in temperature management. They form a closed delivery system for the most part, unless you want to take into account the fluids that go out from the kidneys and fluids that we take in orally. It is considered a closed system that starts and ends at the heart. Of course, that was first described back in the 1620s by William Harvey. He was the first to correctly describe our system. Arteries, capillaries, and veins, if you line them all out, would stretch approximately 60,000 miles in an adult human. That's insane. It's hard to even picture.
That is amazing, isn't it? Can I just tell you one thing?
Yes.
The first hard shell disposable oxygenator I ever used was called the Harvey H1000.
Really?
Yes.
Well, that's really interesting. I love William Harvey. He's an interesting guy. He was brilliant back then.
From way back when, yeah. And it was heresy to say the things he said. There were
really
people
was.
talking about wanting to execute him for this.
Yeah, he had to publish his book outside of his local area so that he wouldn't get such blowback. Okay, so the vessels of the body, our distribution vessels, of course, is going to be our aorta is our main one, and our large arteries. The aorta having its major role in pulse dampening as well as distribution. Pulse dampening, that just means the aorta has a very high compliance. It acts to dampen that pulsatile pressure that happens because of the intermittent injection, the pumping from the heart. The large arteries also are your distribution. That's going to be your carotids, your mesenteric, renal arteries, and so forth. And they deliver and distribute the blood to the specific organs in the body. Under normal physiologic conditions, these distribution, the large arteries and the aorta, really play no role in the regulation of pressure and flow, but they are capable of constricting and dilating. Our resistance vessels These are going to be your smaller arteries and your arterioles. And they are the primary resistance vessels that regulate blood pressure and flow within the organs in the tissue. They are very highly innervated by autonomic nerves. Autonomic just means we don't have control over it. It just does it automatically, particularly the sympathetic adrenergic. And they have a very high percentage of receptors for a lot of our neurotransmitters and hormones that we're going to talk about in shortly. And they use these to signal constriction and dilation in response to the different nerve activity that they receive. Okay. And of course, that's going to be your catecholamines, hormones, and so forth. We'll get into that. Our exchange vessels, this is when we get down to our capillaries and to some degree our venules as well. They play a part more on the reabsorption part. I've got a good diagram of that here shortly. Once you get down to the capillary level, you lose your smooth muscle, and you're composed mainly of just that one epithelial cell and a basement membrane just to kind of hold structure. Even though they are the smallest vessels in the body, they hold by far the largest surface area because they are so numerous. Something to think about, blood leaving the aorta equals blood flowing through the capillaries, but the capillaries have 1,000 times the surface area. So what this means is it slows down 1,000 times because you have a lot of exchange that has to happen. You need it to be going very slow through there. Okay. Of course, exchange is happening between the plasma and the surrounding tissue across the endothelium by a combination of hydrostatic and osmotic pressures. And they have very high permeability. There are different types of capillaries, which I'm going to talk about here shortly, but the things we're exchanging, of course, is going to be our gases, our O2, CO2, water, electrolytes, some proteins, metabolic substrates, byproducts, waste, and hormones. Okay. Our capacitance vessels is going to be our veins, venules, and of course our vena cava. They are capable of dilating and constricting and can regulate the pressure in the capillary beds on the venous side, as well as regulating venous blood volume. So our venous system holds about 70 to 80% of our total blood volume. And most of that, 75% of that volume, is actually in the small veins and venules. So you can see all the different sizes here. Let me get my pen, hold on. Well, there we go. Yeah, so all the different sizes here with, of course, arteries flowing from larger vessels down to the smaller vessels, and the veins, of course, going from the smaller to the larger. Okay. Okay, so this is going to show us the pressures through the different areas of our vessels, with this first part being in the left ventricle, where you have very wide pulse pressure. Your mean pressure coming out is going to be approximately 95, and it's going to be highest in the aorta, where you get that little bounce from the good stretchability that the aorta has. And then it's going to progressively decrease as you get farther and farther away from the heart. At first, the mean pressure doesn't fall that much as the blood goes into these large arteries because they have very low resistance relative to their flow. But the mean pressure drops a lot once you enter into like the smaller arteries and the arterioles, because they are now in a high resistance relative to their flow. Pressure drop through there can be as much as 70%, just because the high resistance. By the time the blood reaches down here, you're going to have a pressure of approximately 25, maybe 30 millimeters of mercury. And this is important that you have that low pressure at the level of the capillaries. Otherwise, you're going to have too much pressure going through the capillaries, and you're going to have large amounts of fluid lost and excessive edema. Okay. This is just the circulatory pressures going through the pulmonary system. Okay, so this is going to show us pretty much what's happening at the level of the capillaries. Here is that pressure going in. My pen is giving me hell. There we go. So that's that 25 to 30 millimeters of mercury that's inside the capillary as it goes into the capillary bed. It is offset by the osmotic pressure of all your plasma proteins. So these blue ones are our plasma proteins, for instance, albumin being our strongest one. And between those two pressures, you end up with a net pressure out of 9 millimeters of mercury. And that's going to give us our filtration pressure at the start of the capillary beds. So it causes fluid to move from an area of higher pressure in the capillary bed to an area of lower pressure in the tissues via this filtration. Okay. Once you get into this middle part, your pressures have kind of negated and you're just getting diffusive motion. Okay. No net fluid movement.
So what you're saying, and please forgive me, is that over here, this, what you just showed, this pressure is convective, not diffusive.
I'm sorry, it's like an ultrafiltrative, yeah.
Right, no, I was
convective.
comparing it to...
Did I say diffusion on that
No,
part?
you
Oh,
didn't. I'm just comparing it to
Dialysis?
CVVH
Correct.
when we do convective versus diffusive clearance. In the
Correct.
body, it's convective, it's not diffusive.
Yes,
I just thought that was an interesting point.
that's true. That's
Thank
very
you.
true. So, and that's the filtration up here. Ultrafiltration, of course, is a convective therapy. And you have a force of 9 pushing that ultrafiltration at that point. With, of course, your plasma proteins staying in your vessels, so they're retaining that osmotic pressure. If you look here, you're 21 on your osmotic pressure going into the capillary bed, and you're still 21 coming out of it because you retained all those plasma proteins, namely being albumin. But anyway, in the middle here, you're just doing diffusion. There's no pressure gradient anymore. Everything is kind of negated in the pressure area, and you're just having going down concentration gradients. Okay. By the way, this is what we're talking about when we're talking about perfusion of the tissue. If you drop your blood pressure at the aorta or where you're taking your cuff pressures or whatnot, you no longer have this 25 to 30 millimeters of mercury going into the capillary bed. If you don't have that, then you aren't diffusing anything via the filtration, meaning all your gases as well as your nutrients. So this is how you end up in that ischemic tissue and things like that. Okay, and then on the venule side, now we have a lower pressure on the venule side now is 15 because you lost a lot of that fluid coming out, right? Which means our osmotic pressure is now the greater pull. So you have a 6 millimeters of mercury pull back into the vessel, and this gives you your reabsorption of bringing fluids and so forth back into the vessel. Okay, these two types of pressure, so being your hydrostatic pressure at the entrance versus your osmotic pressure at the exit, are always interacting with each other, and they kind of drive the movement of all of these substrates and such at the tissue level. Of course, capillaries do not function independently. They work as capillary beds, and they're numerous. There's not even a smallest area of our tissue that is not covered by a capillary bed. And of course, this is required because this mass movement of fluids into the capillary beds, into the tissue, requires something a lot more efficient than just diffusion alone, which brings us to, what Joe was saying, that adding in that convective therapy and the reabsorption to it. Okay.
So I have a
Capillaries.
question.
I'm sorry?
I have a quick question.
Oh, go ahead.
The vasoconstrictor drugs that we give in perfusion, they are neo, vaso, and norepi.
Norepi.
Right. They all constrict the capillaries on the venial side. Is that right?
So that actually brings me to my next point. Capillaries at this level don't actually have any smooth muscle. So any changes in diameter that they go through is more passive. And they maybe will receive some signaling molecules from the tissue surrounding them, but for the most part, you're not going to have at the capillary level reaction to those vasoactive medications. That's going to be in your arterioles.
Okay.
And
So
to
when we
some
squeeze
degree in the venous side, but arteries have much more of that smooth muscle around to get that reaction.
Yeah, that's interesting. So when we're squeezing the arterial side, we're increasing the pressure here, and then it allows for a higher pressure to go through the capillaries for the diffusion, right?
Yes.
Okay.
Which
I just kind of want to make that
they
perfusionist.
spread way out.
Yeah, a lot of
Right.
perfusionists, they give drugs, but they don't understand where the action is happening at.
Well, it's not gonna
To understand where,
So if you increase your systolic blood pressure systemically, like up in your aorta area, your capillaries have a fantastic ability of just totally dispersing that pressure because they're so numerous. So they maintain this 25 to 30 just because there's so many of them to spread that pressure out. The pressure drop is going to be loosening that flow by up to 1,000 times. So it's not gonna change too much at this capillary level unless your pressure goes low, because you're going into a very low pressure down at that level. So if you lose pressure at the upper end, you got no pressure at the capillary level, and then you have no activity at all.
because that's the second point of for perfusion related information. Higher flows will facilitate this transfer at the capillary level. So you don't have to give as much vasoconstrictors if you're flowing high enough.
Yes, I would agree with that. Does that sound? Am I understanding him correct?
Yeah, I think so. I think that
I don't think it changes the pressure in the capillaries themselves.
No,
they
I don't.
Spread it out.
I think what he's saying is, and what I've said as well, the best treatment for hypotension in the operating room on bypass, if you can, is to increase your flow, not just vasoconstrict.
Yes. Okay.
I think that's what he's saying.
Is that what you're
Yes.
talking? That makes total sense to me.
Yes.
Okay. Now we have three main types of capillaries. We have a continuous fenestrated capillary, and they have small openings, and they allow for the rapid exchange of these substances, and they are in areas that require a lot of exchange. So like your kidneys or your small intestines or endocrine glands and so forth. Then you have the continuous non-fenestrated. They have a lining that contains smaller gaps between their endothelial cells, and they allow for the gases and the water and the glucose and some hormones to pass through. And this one exists in the muscle tissue and the fat, and it's the most abundant and most common one, as you would suspect. Then we have a more specialized capillary bed that's called the sinusoidal, and they have different type of fenestrations that allow certain substances to pass through, such as bone marrow has to let red blood cells into the circulation, which normally do not go through capillaries, right? So these sinusoidal capillaries are in areas that require the red blood cell to be able to enter there. So bone marrow, liver, spleen, it has to be able to allow the defective cells to exit, and so forth. So the three main types. Any questions? Okay.
No, very good.
All makes sense. Okay, so all of our vessels share common layers, or tunics is what they're called, be them arteries or veins, except when you get down to those tiny capillaries who don't necessarily have that smooth muscle layer. But the innermost layer, or the tunica intima, is just simple squamous epithelium surrounded by some connective tissue to kind of help hold shape, and a basement membrane, some elastic fibers. It is exposed to and interacts with the contents of the actual lumen, and mostly it provides like a frictionless pathway for the blood to travel along. Okay, and of course it is present when you get down to the capillaries so that it can do a lot of that exchange. Incidentally, some of this basement membrane is actually there to prevent those substrates from diffusing and filtering out before it gets to the capillary bed. It wants to keep everything in there until it is time for it to change out. Okay, our middle layer is the tunica media, and it's composed of that smooth muscle and elastic fiber. It's usually the thickest layer, and it provides a lot of support for the vessel. It can change the vessel diameter because it has like transversely arranged smooth muscle cells that can vasodilate and constrict. Of course, with that sympathetic innervation, the involuntary autonomic system regulates that. This tunica media thickness varies pretty widely between the different vessel types. So it's very thick in some arteries and almost non-functioning in some veins. And we'll talk more about the veins here in a little bit. The outermost layer, the adventitia layer, attaches the vessel to the surrounding tissue, and it's mainly connective tissue with varying amounts of elastic and collagen fibers. It's very dense, and in veins it changes to like a looser connective tissue as it gets further out from the middle of the vessel. And it's mainly responsible, like I said, for connecting it to the surrounding tissue, but also helps hold that vessel integrity and physical wall strain and so forth. It also houses the vasa vasorum, or the vessels of the vessel, so the tiny blood vessels that actually support blood flow to the vessels themselves. Same with the nerves on the vessels, so that's all in those layers. Okay, here's another awesome looking slide with good stains showing the difference of these layers between the vein and the artery. So our main difference, of course, is this middle smooth muscle tunica media. So that's this thick layer here on the artery. If you look at the vein, you can see it's much thinner, so much less smooth muscle is present there. And when you get to the externa, you can see down here on the artery, on the vein, it loosens up and gets much less dense the further out from the vessel it goes. Also, the vein is very collapsible because of some of the changes between them, or the differences between them that we just discussed with those layers. Matter of fact, veins, especially their larger veins, are supposed to collapse up to 50-60% just with regular respiration for normal volume status. That's called segmental differentiation, the changes between the different layers in the arteries and the vein.
You know, I think it's really cool to watch the anesthesiologists put in their catheters, and they'll be doing it with an echo machine, and they'll push. You can see the arteries, and they'll push on it, and you can see the arteries squish or the veins squish. I think that's so cool.
It is. It is. So if you are, if your volume overloaded, your vessel doesn't collapse. That's one of the things that I find particularly useful with the bedside ultrasound, just to assess kind of the fluid status of your patient. You don't even have to press down on the vena cava. You can just watch it. And if it does not collapse with normal respiration, you're overloaded. It's very diagnostic. Okay, so with every mechanism that the body has to increase something, it must also have a mechanism to decrease the same thing, so that you don't end up with this runaway loop, which is kind of what a positive feedback loop is. So good examples of this would be like cruise control or air conditioning. Where, well, actually, I'm not going to use that example. Positive feedback is where you get a reaction, the body senses it, and it wants more of that same reaction. So if you start clotting, it wants to make more clots, or, those type things. Good examples of where that is helpful would be contractions, like during childbirth, where you get a contraction and it causes more intense contractions to go from there. There is some positive feedback mechanisms to blood clotting, with a lot of protective inhibitory steps in that process to protect us. So positive feedback is a mechanism resulting in the amplification or growth of an output signal. And really, it's a breakdown of the homeostasis of the system. And there you have the examples. So negative feedback occurs to reduce the change or the output. So that's kind of like our reel it back in mechanism. So we can compensate, correct things, but then reel it back in. Okay, bring it back to a stable state. So negative feedback senses the change, and it activates mechanisms to reverse it. And this is how we have inherently stable systems. It allows the system to self-stabilize. And these are good examples. Mainly our blood pressure is the examples that we probably deal with most commonly in the critical care, but also glucose, body temperature, fluid balance, electrolyte levels, and pH. This is where our cruise control example should be. So if you're on cruise control, the car senses it when you go above the speed limit and it slows you down. Or if you're going too slow, the car will speed you up. Same with air conditioning. They're just in the wrong spot. They belong with the negative feedback side. Let's see, temperature. Yeah, I think I covered all of that. Does everybody understand that part? We want the negative feedback loops. That's how we bring it all back in. Okay. Okay, here are some good examples of our negative feedback loop. We're going to talk a little bit about this one here in a little bit. This is heart rate. So baroreceptors sense that. They send it to your glossopharyngeal nerve, which then sends it back to your vagus, to the cardiac pacemaker, and it decreases the heart rate. So it's negatively, it senses the fast heart rate and it acts to slow it down. Same thing with our blood pressure. So if our blood pressure goes up, our arteries are stretched, those baroreceptors sense that, and they send those inhibitory signals, which increase vagal tone, reduces heart rate, brings down the blood pressure, or reduced sympathetic tone, reduced vasomotor tone, which causes vasodilation, of course, reducing the blood pressure. So two very good examples of our homeostatic negative feedback loops. Clear my markings, sorry. Okay, so arteries. Main feature of our arterial system is that it is high systemic pressure and a low volume system. 10 to 15% of the total blood volume sits in our arteries. They have an abundance of elastic tissue, and those elastic arteries are the ones nearest to the heart. So your aorta and your pulmonary arteries, and they have much more elastic tissue in the tunica media than in the muscular arteries. And that's because, as I mentioned before, these large aorta area vessels aren't really that active in constricting and regulating blood pressure, so they don't need that thick, smooth muscle layer. They do, however, need that elastic layer because it allows them to maintain a relatively constant pressure gradient despite that constant pumping action of the heart. So having all that elastic tissue lets them handle the force of the blood coming from the heart. Elastic arteries, of course, feed the muscular arteries. This is just a diagram of an elastic artery over here. Muscular arteries, they include your named arteries, so brachial, radial artery, femoral, and they are the arteries that have much more smooth muscle in that tunica media layer. Okay. There are no valves in the arterial system, although I would argue that the semilunars count as 2 valves in the arterial system.
Technically, yes.
Yeah.
Technically, the aortic valve and the mitral valve, specifically.
Oh, the aortic and the pulmonic.
Well, yes, that's technically arterial, but I'm thinking arterialized versus... So I was thinking, so then there has to be 3, because then there would be the mitral.
Mitral is not taking blood away from the heart. It's receiving blood from the lungs. That's a vein.
No, the mitral valve is between the left atrium and the left ventricle.
Right, and it's receiving blood from the pulmonary veins.
Technically, you are correct. Okay, I can't argue with you this morning. You're right.
It is arterialized, but the definition of an artery is a vessel that carries blood away from the heart, not oxygenated blood.
This is true. That's true too. I agree with you. Okay, so you are correct. Moving on. I'm not saying anything else this rest of the day.
Pulmonic and the aortic valves would be the only 2 valves in the arterial system.
Fair enough.
I win.
You do. You win. Here, your PerfWeb cup.
Thank you.
Give her the hat.
Okay. So I think I covered everything there. So our muscular and elastic arteries. Again, it's really important for the aorta to be that elastic. That's where we get that arterial waveform at the aorta level. It gives us that extra bounce and that pulse dampening. If you look at an aortic waveform, it's a lot less spiky than, say, a radial arc line waveform, and that's because of that very elastic quality that the aorta has. I think you did a presentation on the waveforms at one point.
I think I did your presentation on the waveforms, and it wasn't as good.
So that's a good time to bring up, some previous PerfWebs that we've done. And I think I did a big talk on it in the PerfWeb 97. So if you're watching this, you can go back and see our other PerfWeb talks, and they bring everything together. Sometimes we talk about things that from a disparate perspective, and it allows a better understanding. So go back and look at PerfWeb 97. I think both Vicki and I had talks on that.
Thank you. That's actually a very good idea.
Okay. Now we get to the meat of it for our arterial regulation. So in general, an individual's blood pressure or systemic arterial pressure refers to the pressure within the large arteries. That's where we measure it at. You have your systolic, which is the highest, most pressure, versus our diastolic, which is the lowest, most pressure. And it's because of the pulsing of the cardiac cycle. The role of the arterial pressure is to maintain a high enough pressure for proper perfusion to the body temperature, to the body tissue, but not so high as to cause harm. And this is all regulated through vascular tone. Well, this is just talking about the pressure being definitely corresponding with our cardiac output, the arterial elasticity. Our peripheral vascular resistance is mostly made up of our small arteries and our arterioles, and otherwise known as our SVR. I don't want to leave that part out. Okay, so vascular tone.
And that's a question.
Yeah, go ahead.
The words do not cause harm. What are examples of harm?
For example, the kidneys in particular, if you have a blood pressure over, say, 180, they lose their autoregulatory features and you can cause damage to the capillary beds there. For sure.
Stroke,
yeah.
increased risk of stroke. Yeah, the organs, the parenchyma of the organs aren't designed to manage that kind of pressure load. So you just it's just excessive pressure. It's kind of like having a joint go bad because you are a person who does high impact calisthenics every day of your life. Your joints are probably going to wear out a little faster than somebody that does low impact. Given the joints are the same strength to begin with. Yeah.
So my observation on this is a question of, is this high blood pressure brought on natively? So, resulting from age and stiffened arteries, and also giving too much constrictors, which are constricting at the arterial level.
So,
and then
I think in general, high blood pressure is a result of that runaway positive feedback loop that I was talking about. So patient has a lower cardiac output. The body wants to compensate by increasing the SVR, its main compensation mechanism initially, right? That increase in your SVR reduces your cardiac output further, and you end up in this cycle of high blood pressure causing remodeling of your heart and so forth. One of the reasons why we have to prescribe ACE inhibitors and so forth.
Said that they can't hear Vicky very well.
Oh, sorry.
It's not you.
It's him. Oh. So, for
I guess
instance,
in the world of perfusion, we're different. From your end, you're dealing with a patient that is, they are not on bypass. And when we go on bypass and we add a circuit to the problem, we end up physically controlling a lot more things using drugs. And I guess the point is, or the question is, when you, in addition to having the complications from high blood pressure that we know about that are internal to the body, by giving too many constrictor drugs, we can also cause shunts around these organs. And that's where the organs can get damaged from.
So, and especially if you're talking about bypass patients, you can blow a graft.
Right, but then you're getting, I think he means too, what he's saying is anyone on cardiopulmonary bypass, it could be a valve. So I think what he's trying to say, and we could distill this down a little bit, because you're dealing in normal physiology. You're not dealing in deranged perfusion physiology, cardiopulmonary bypass. This is more or less normal physiology that you're trying to describe here. But what he's saying is when we go on bypass and we have continuous flow acutely from pulsatile flow, and we use a lot of pressures, we can get a lot of shunting around the capillaries.
Oh, I see
So
what you're
that, or we
saying.
call it capillary bridging.
I see.
And what happens is you get perfusion deficits at the tissue level, lactates go up, blah, 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 blah,
Wherever.
blah.
Okay,
That's
I
what
see
he's
what
really,
you're saying.
that's what
Yes.
he's talking
I
about.
do understand that
Exactly.
part.
So
So
your two
we're in
are,
the presence of
mhm,
normal
yeah,
flow,
Good
a
point,
normal
though.
blood flow,
Good point.
but we're actually causing a deficit. Joe understands me.
yes, because I have the same exact thought. Yes, we're looking at it from our perspective, from the perfusion perspective. And she's trying to just I think what she's doing is expressing the basic physiologic fundamentals before you get to now, we're going to do this to you, and what's that going to do? So, but those are all
Yeah.
very good points. I agree. Please, I'm
Yes.
so sorry.
And I guess
That's
the
okay.
question is, I like to try to tie in the perfusion aspect or what Vicky's talking about so that, because that's the topic. The topic is how these things affect perfusionists. And that's what I'm trying to do here. But the other thing I was going to bring up was,
I can't.
are you okay?
No, I'm good. They're yelling at me about something else. Go on. I'm going to go over there. You guys talk.
Go ahead, Thomas.
Okay. So the next thing is, frequently as a perfusionist, we end up in situations where we're underflowing
What's the problem?
and we can't do anything but
problem?
increase our flows.
I heard you say
And
my
then
name.
we end up in a cycle of badness. And some people use the word vasoplegia, and I use the word vagal tone. And what
Yeah,
happens when you're
can't
flowing
fix that.
lower or not flowing enough?
Yeah, and he breaks up
You end
because
up
he's on
going.
Wi-Fi.
You end up
He's in
having
the hospital.
low blood pressure.
Yeah.
And
Well, whatever.
at the capillary level, they
I just wanted to
actually
I-
go into a cycle where they keep on dilating there. And so you end up with even less volume in your pump, and you still can't flow.
Yes.
And you're flowing less and less. And what's happening is there's just been this cycle of vasoplegia or vagal tone loss. And to fix that, as a perfusionist, there's two things you do. The first thing you do is drop a lot of volume, like 2 liters of crystalloid. It's something that you have to do. You're going to take the hit on hemopollution. You're going to take the hits on the side of fluid going into the cells. But don't worry about that now. You've got to get your flows up. So the first thing you do is just drop 2 liters, sometimes 3 liters of crystalloid. Get the flows up, and at the same time, slam them as hard as you can with a lot of constrictor, either Neo or Norepi, and really squeeze them hard. And then, once you finally establish the vagal tone again, you can now hemoconcentrate all that crystalloid that you gave off, and it'll catch you back up where with everything that you lost. But don't forget, you've done a lot of damage to the patient, but it's something that had to be done. And I just want to bring that up. So if anybody ever has that situation of you just keep losing your vagal tone, that's what's happened. Mm-hmm. And because you would be surprised at how the capillaries, there's so many of them that when they dilate, all the volume goes into the capillary area, and it's not going into your pump, which means you have to flow less. And then the capillaries dilate more. No volume in the pump, you have to flow less. And so that's the cycle that happens in the real world solutions for it.
Mm-hmm.
Very good. All very good points.
Mm-hmm. Yes. Okay, so vascular tone. This is determined by the competing vasoconstricting and vasodilating influence that act on a blood vessel. They're kind of separated into extrinsic factors, so factors that originate from outside the organ or tissue in which the blood vessel is located, and intrinsic factors that originate from the vessel itself or the tissue surrounding the immediate area of the vessel. The primary function of the extrinsic factors is to regulate arterial blood pressure by altering the systemic vascular resistance, where intrinsic mechanisms are important for regulating local blood flow within an organ itself. Okay? And we're going to go through these, but you can see Your extrinsic factors over here, your neural, so your neurotransmitters and your humoral transmitters, and your intrinsic over here, which we're going to go through. Okay, so intrinsic factors. So tissue factors are the ones that are produced by the tissue surrounding the vessel, and they can cause constriction or dilation to alter the blood flow to basically to itself, to the vessel that is perfusing that area. And usually these are released in response to increased metabolism, where it signals the need for increased blood flow. So this is going to be your carbon dioxide, okay, your low O2 or your high O2 consumption, and then of course your potassium, osmolarity, those type of things. These all act as vasodilating effects so that it can open up the vessel and allow more blood flow to come through and supply that increased metabolic need. Carbon dioxide is a particularly important factor in cerebral blood flow because it forms that hydrogen ion, which acts as a potent vasodilator. Potassium, of course, is going to be more important around the skeletal muscle because of all that rapid depolarization. And it can help cause muscle relaxation to increase the blood flow. And of course, oxygen levels can cause vasodilation around the lungs to kind of help that process happen. Okay. Local hormones, so histamine, this is released by mast cells in response to injury, inflammation, and of course causes vasodilation because it wants to improve flow to the area so you can get more of your immune system factors to the site of the injury. Bradykinin, it stimulates nitric oxide and prostacyclin, and one of the enzymes responsible for breaking down bradykinin is, of course, your angiotensin converting enzyme. So if you take an ACE inhibitor, you are increasing how much bradykinin you have. So it's used to treat hypertension. Okay, myogenic factors is just kind of like a reflexive control mechanism when the lumen expands on the vessel, as with like a higher blood pressure. The smooth muscle contracts to restore that vessel diameter and the correct resistance in the system. Same as when the lumen is reduced, the smooth muscle will relax to allow the vessel diameter to expand back and to correct the resistance in that direction. Okay, so it is an immediate involuntary response to sudden changes in your lumen size. And of course, that's going to be our small arteries and arterioles that are mostly responsible for this, and they make up our SVR. Okay. Endothelial factors. This is where the endothelium produces its own vasoactive substances. Nitric oxide and prostacyclin being our main one. They are very potent vasodilators, and they're usually triggered by shearing forces. They can be triggered by hypoxia, inflammation, endocrine or hormonal signals. A lot of things can trigger that. Endothelin-1 is a powerful vasoconstrictor, and it is actually, I believe it's the most potent vasoconstriction that's formed and released by the cells themselves. And it's stimulated by angiotensin 2. I think vasopressin can stimulate this, reactive oxygen species, and it's actually inhibited by nitric oxide. So nitric oxide is kind of like a regulatory check system, one of our negative feedback to prevent endothelium from just running away with that blood pressure. Any questions there? Okay. Okay, so our extrinsic stimulus. So this is our autonomic neurocontrol. Of course, this is going to be our sympathetic and our parasympathetic. I think we're all pretty familiar with that one. It's controlled by the central nervous system. And this is where you get your alpha and your beta receptors. We're going to talk a little bit about that here in a minute. Both systems are always active with some degree of nervous input to the tissues at all times, and it's kind of regulated by suppressing one or the other. And of course, its stimuli is such things like stress, trauma, pain. All of those things will put you more on the sympathetic activity side, and this always directly increases your vascular resistance. Major arteries and precapillary arterioles are innervated by sympathetic nerves, but other vessels such as your veins and your capillaries and collecting veins really aren't that innervated, and they don't really participate so much in that constriction like we mentioned earlier. Okay. Epinephrine and norepinephrine. These are going to be your main neurosignaling, I guess, molecules. And they have equal affinity to beta-1 receptors and adrenergic receptors of the heart. Okay. Sympathetic is our fight or flight. And then, of course, our parasympathetic is going to be our relaxed vasodilation system. And it's more of an inhibitory to your sympathetic. Okay. All right, our baroreceptor reflex is another mechanism that helps regulate the vessel tone in response to acute changes in the blood. The body responds through the baroreceptors. Located within the upper part of your aortic arch and also in your internal carotids up here is these little yellow dots, and they become activated by stretching of the vessel. They send information to the central nervous system, and they influence peripheral vascular resistance and cardiac output to correct that stretching. So activation of the aortic baroreceptor during increases in blood pressure inhibits your sympathetic nerve response. Okay. If your blood pressure was to fall, so like hypovolemic shock, it would lead to a reduced inhibition of the sympathetic activity. And that's kind of how it regulates it. All right, so our carotid and our aortic baroreceptors, these are our high pressure baroreceptors, and they are what's signaling in our arterial system. Our low pressure baroreceptors are present in the lower pressure venous system, so large veins, pulmonary veins, and walls of the right atrium and the right ventricle. So the venous system has a compliance 30 times greater than that of the arterial system, and changes that influence the baroreceptors in the venous system will lead to like the secretion of antidiuretic hormone, renin and aldosterone, things that would regulate volume in like difference from the arterial system that's regulating cardiac output and blood pressure and SVR.
Right. Can I say something real fast?
Yes.
The that vasoplegia loss and vagal tone loss that I was talking about earlier, they are directly associated with the baroreceptors, and that's a result of stretch. The baroreceptors work off of stretch, and when they don't feel that stretch, they want to tighten up, or they want to cause an increase in blood pressure, or cause a decrease in blood pressure. And so part of the loss of vasal tone and vasoplegia is it is being controlled by baroreceptors.
Yes, I would say that's probably the most immediate response to drop in pressures is going to be picked up by those baroreceptors first and initially. I would agree.
Oh, be right back.
Oh, okay. All right, so ADH, or antidiuretic hormone, also known as vasopressin, is produced in the hypothalamus. It's synthesized and released in response to high serum osmolality. It can be released in response to low blood volume, decrease in blood pressure, or an excess of angiotensin II. So that low blood volume causes decreased stretch in the low pressure baroreceptors of the venous system, leading to an increased production of ADH. Kind of wants to correct this pressure problem with increasing volume versus decreasing volume. ADH mainly functions to increase free water reabsorption in the kidney, and it causes an increase in that plasma volume and thus an increase in arterial pressure. In high concentrations, it also causes vasoconstriction, increasing peripheral vascular resistance and arterial pressure pretty directly as well. Okay, the renin-angiotensin-aldosterone system, your RAS. This is a good regulator of your arterial blood pressure, starting off with angiotensin 1, converts to angiotensin 2, which goes to the antidiuretic hormone and aldosterone. Aldosterone, of course, keeps sodium in water and causes vasoconstriction, resulting in an increased blood pressure. Antidiuretic hormone, increased water resorption and thirst. That thirst mechanism can be pretty strong too. I've had patients that were just about to code and all they wanted was a drink of water. They feel it pretty intensely. Vasoconstriction in the efferent arterioles within the glomerulus of the kidney, so it adds more back pressure to that glomerulus. Okay, so that brings us to our adrenergic receptors, alpha 1, alpha 2, beta 1, beta 2. I know we've all heard these and you probably know which drugs are which. But this is talking about the response to the actual signaling molecules. So alpha 1 causes vasoconstriction, which directly increases your peripheral resistance, or your SVR, which increases your blood pressure. And then if you go into the whole fight or flight mechanism, it's going to close that bladder sphincter. Mydriasis is just the kind of like the eyes kind of exerting more focal power. If you have your beta 2 is going to relax the bladder, where your alpha 1 constricts the sphincter, because you don't want to feel that bladder pressure while you're under stress. So you have to have both constricting and dilation going on at the same time. Okay, and that's true for several different places in the body. Alpha 2, this inhibits the norepinephrine release. It inhibits acetylcholine release and inhibits insulin release. Okay, beta 1 is going to be increased heart rate, increased lipolysis, increases that contractility of the heart, and increases renin. Beta 2, this is where you're going to have that vasodilation. You're going to decrease peripheral resistance, Bronchodilation, that one's a big one for your NEBs, your albuterol. Glycogenolysis for your muscle in your liver. Glucagon release. And of course, it relaxes uterine smooth muscle. Okay. Here are our main drugs, with epinephrine having pretty strong effect on alpha 1, alpha 2, beta 1, beta 2. With this being somewhat dose dependent, you get different effects at different layers of this. So the higher dose you get on epinephrine, the more you're going to be just alpha. Lower doses are going to have that stronger beta effects. Norepinephrine is going to have strong alpha with a minimal beta. This one is a good medication to use if you are also on like an inotrope where you need the cardiac output to be enhanced, but your blood pressure goes down. You don't want to use something that's just SVR. You want to use a medication that gives SVR, but kind of also a little bit help to offset that SVR with your beta 2, your inotrope. Dopamine acts on dopamine receptors, and it is strong inotropic at lower doses. The higher you get, the more peripheral vasoconstriction you get. And these are your dose dependent over here. Okay. All right, so let's go to the veins. Our capacitance vessels. Of course, as I said earlier, they hold up to 70% of all the blood in the body, and out of that 70%, 75% of that is in the small veins and the venules. Okay. They have the same tunica as arteries, so they have a thinner tunica media, less smooth muscle and connective tissue, and wider, looser lumen than arteries. You have three main compartments of the venous system. So your deep veins, your superficial veins, and your perforator veins. Your superficial veins are those closer to the surface of your skin. They don't necessarily have a corresponding artery with them. Deep veins are deeper in the body, and they usually do have a corresponding artery. And then perforator veins drain from the superficial to the deep veins, and they're usually in like the lower limbs and feet. Okay. And you can see the different layers here. Veins do have valves in varying numbers, with the majority of them being in your lower extremities because that's where gravity is having the hardest effect on them. Here is a lovely video of a vein in your popliteal. You can see the valve catching every single time that you get flow back through muscular contraction, and that valve opens and closes to prevent backflow of the blood back down the system. It helps fight the pull of gravity, and it also gives some kind of like stability to the vessel wall itself. And kind of prevents over widening. So to prevent that regurgitation.
Yeah, the loss of integrity of the valves, and you get big varicosities.
You get the varicosity veins, yes. Mm-hmm. So they're, like I said, very prominent in the deep veins of the lower limbs, such as the common femoral vein, your popliteal, of course, right here, and your tibial, fibular veins, with varying numbers of valves throughout them. Like some of them have 3 or 4, sometimes they'll have 4 or 5. It can vary. Okay, and of course, skeletal muscle. Contractions help pump the blood towards the heart just by compressing the vessel wall itself. Giving it a squeeze, the blood gets pushed through the valve, but it can't come back through because the valve closes. You also have the thoracic pump. So you have a negative, kind of like a suction effect from your intrapleural pressures during breathing that acts also as a pump for venous return. Okay.
Could you mention the shunting that takes place whenever you take out the leg veins to do a coronary artery bypass with those leg veins?
You mean when you take the graft out?
Yes. Not the graft, but the actual veins themselves
The
from the
vein.
leg so that you can do cardiopulmonary bypass. Where does the shunt happen? So that now the blood can still return back to the heart without those major veins.
I mean, I just think I can answer the question for you.
Yeah.
So I think what he's asking is, you know, what happens when you take the greater saphenous, the entire length of the leg of the greater saphenous, and really it just comes down to the venous system is so much more abundant that the other accessory vessels just are able to accommodate it. It's pretty uncommon to develop venous insufficiency from taking the greater saphenous vein. So really, it's just, you know, it's just it's an abundant system, and there's plenty of other opportunity for other vessels to pick up the slack, so to speak.
It just kind of accommodates that extra volume.
Yes. Yeah.
Yeah. I do notice they have more swelling and edema in those legs for some period of time too.
That could be trauma.
Trauma.
But it could also be some, but I mean, it's going to adapt.
Yeah, it does.
You know, we do it an awful lot.
We do.
Yeah.
We do. I imagine it kind of messes with the lymphatics through that system as well, at least in that one area.
Maybe so.
Maybe.
So.
Right.
Good answer.
Thank you, Joe.
I'm not sure that I helped, but you're welcome.
No, makes sense.
Well, I just see a lot of perfusionists. We watch this all the time, and you think about it, you just kind of take it for granted that it must work.
Like it
and we do it.
just works.
Yeah. Yeah. You can lose an awful lot of veins and not have a problem, especially
right.
those in the peripheral, in the periphery. You can't lose your IVC, but you can lose a saphenous vein.
Yeah, they are much more abundant. You're right about that. I'm not sure the
We have a greater
percentage, though.
saphenous, you have a lesser saphenous. But anyway, moving on. You can lose a lot of vein. Go ahead. I'm sorry.
Oh, you're fine. You're fine.
I don't want you to run out of time.
I think we're going to be okay on time.
You do? Okay.
Yeah, we're going through it a little faster than I thought we would.
Oh, good.
Maybe.
Okay.
Maybe. We'll see. We'll see. All right. All right. So, venous constriction, of course, decreases the venous blood volume just by making the tank smaller. It increases venous pressure, which pushes more preload into the heart, increasing cardiac output. It increases your right atrial pressure and your ventricular preload. Okay.
God, for a minute there, I thought you were suggesting that we do rap.
Ah,
Increases rap. That was you almost sent me into a tailspin here.
I'm not.
Thank God.
But what about suggesting that we use PRP?
Dude, come on. Don't start. Pixie dust.
Okay. So our CVP is basically the blood pressure in our venous compartment. And it's important because it kind of tells us the filling pressure to the right atrium and feeds into your ventricular stroke volume. And of course is all working along that Frank-Starling curve, which I really thought about putting in here, but I decided to spare y'all. I'm sure everybody's pretty familiar with Frank-Starling's curve.
Yes.
But that's where we're at with this one. Our CVP is affected mostly by mechanical factors like our respiratory activity, that respiratory thoracic pump I was talking about, contraction of our skeletal muscles, especially the legs and to a big degree the abdominal muscles. And of course, respiratory activity can impede or promote the return of blood into the central venous system just by compressing and releasing on that vena cava. You also have CVP influenced by cardiac output, of course. Valsalva is where you put an excessive compression on your vena cava. SVR, venous compliance, and of course total blood volume, which I put last because CVP is not a very good indicator of total volume. It's a pressure. Okay. Gravitational forces significantly affect venous return, and thus cardiac output and arterial and venous pressures. So over here you can see when we are supine, you have a good portion of your venous volume kind of hanging out around the heart. So pressure from one end to the other is mostly the same, and you have good return. If you were to stand up, all that volume falls down to the legs and the feet. As a matter of fact, the pressure down here can even reach as high as 90 millimeters of mercury on the venous side, just because of that gravitational force. This is also, of course, what causes orthostatic hypotension. Usually, your very immediate response to this is those baroreceptors, and they correct that action fairly quickly. But anybody who has stood up too quick and got dizzy, there you go. That's it.
And now they have the new thing that all the cardiologists seem to be so in love with, which is POTS, postural orthostatic tachycardia.
Is that just where the volume goes back and it forces the heart to speed up?
Yes.
Yeah. I mean, that makes sense. Your body has to try to regulate anything, right? So when you stand up, the baroreflexes are very rapid, and you restore that arterial pressure, usually and most immediately through systemic vasoconstriction on the arterial side. A decrease in cardiac output can increase CVP by backing it up into the venous system. It's no longer getting moved forward as fast. A decrease in SVR by arterial dilating can increase your CVP because it's pushing more flow from the arterial to the venous side.
Yeah, and in bypass surgery, when we do cardiopulmonary bypass, there's probably three big things that relate to the higher CVPs that are indicating that you're going into right heart failure. And that's first, that the left heart is having a problem, and it's usually because the vein graft that you just put on the heart is going down. It's not in the right spot, or it's too tight where they put the sutures, so that the heart's not getting the oxygen that it needs. Or you could have air in the coronaries from just bypass.
Does that happen a lot?
And then all of
error
those things cause them to
in the corner?
cry.
Yes. Yes.
I did not know that.
There's
Will fall over to
frequently
the
a
right
lot of
heart.
air in the coronaries.
I did not know that.
And that'll raise the CVP.
Yeah. If you only knew what we did to people. But
Well,
those
you're
are
gonna,
very,
you're gonna tell us in a minute, right?
yeah, those are very, yeah, exactly. Most people just don't know. I'm going to address that a little bit. But no, that's a very good point, Thomas, actually, and I'm glad you brought that up. But it is something we see very frequently is post coronary bypass surgery as we're trying to wean off bypass, you start seeing, left heart failure all of a sudden. And then you watch that whole process go back where you'll see the CVP, the PA starts climbing, the CVP actually starts climbing. And you can differentiate it, what he's saying, because if you have right heart failure, your PA pressure really doesn't climb that much because you're not getting the blood into it. When it's left-sided failure, you see those PA pressures really start to climb a lot faster.
Of course.
Right, and
Can
you'll
I
also
add-
see the blood
Go ahead.
left side go.
Yes.
Blood pressure on the left side goes down, and the
Right.
backs up side where you're seeing your PA pressures go up. And so as a clinician right away, get the balloon pump, and may not actually have to use it because maybe anesthesia can get their act together and give the drugs that they need to give. And in the meantime, you have your balloon pump, get the balloon pump stuff in the room, and then also you're thinking in your head, how close are we to having to go on to an ECMO station, an
Yeah.
AVM?
Yeah, I think that you have to, differentiate. You're breaking up a little bit, just so you know, Thomas, but I think I'm understanding everything you're saying. I think what he's
Yes.
trying, what Thomas is saying is that you have to first of all differentiate what is the problem here. Is the problem a technical problem with the graft itself, meaning now the heart in whatever area is ischemic and failing? Is it air, which is again not uncommon, and the appropriate treatment for that is to drive the blood pressure up transiently to try and force that blood through the coronary and relieve that obstruction that's being caused by it. And sometimes it's CO2, sometimes it's air. It just really depends. There's a variety of things that can cause it. And I think that's what Thomas is saying, is that, when
Exactly.
we see, and then you have to, so if it's not a technical issue with the graft, and anesthesia can't now correct the problem with pharmacology, driving the SVR up, the pressure up, and increasing inotropy, so you just get a really good cardiac output and high blood pressure at the same time, then you have to be thinking to yourself, if it's not, the graft is down and they're going to redo it, I'm going to need a balloon pump. If the graft is good and this is still a problem, we need some type of mechanical circulatory support to get us through this, and sort of the evolution of all of that.
Right.
I mean, I'd say
And
we kind
the
of go
fun-
by the same algorithm at the bedside, if we
Yes.
see that patient going into the different side of, whichever heart failure you're going into.
And then I
We
think
use the same
probably
numbers.
the other thing you have to keep in mind is the actual first step is look at your pressure monitoring stuff. So is your transducer too low? And that'll make your CEP artificially look high. And is your are you in a constricted state in the arm, the radial artery, and it's dampened? And then you go down the algorithms of failure.
Yeah, no, that's absolutely correct. And then can you actually trust your arterial line? Hey, Magic.
Right.
Can you even trust it? There was one other thing I wanted to bring up if I could.
Sure.
And that is the mechanism when you have a patient in this supine position, maybe you could go over this. How can you tell if your hypotension is due to hypovolemia or vasodilatation if all you have is a systemic, a radial arterial line in? What would be I know what mine would be. I know yours is going to be the same. So what's a good way for a critical care nurse or even in the operating room to determine if your hypotension is due to hypovolemia or some other cause?
I mean, I would do a passive leg raise.
Leg raise, exactly. I mean, you have any idea how many people still don't know how to, still don't do that?
Oh, I do it pretty regularly,
Yeah.
actually.
Yeah.
But in
You
your critical care unit, I'm talking OR. It's
Oh.
always very different back there.
Do they do it in the OR?
Right.
No, they're terrible at it.
Oh, okay.
And
It can- it
you
can
can put them in
definitely
you can
get an
put them in
immediate
Trendelenburg
response.
or just take and lift right. If you lift the legs and you see the blood pressure going up, you know that patient is hypovolemic. That patient needs volume.
Sure. It's like a 350, 400 cc bolus.
It's a pretty good amount, yes.
Right.
Go ahead. I'm so sorry.
Oh, yeah,
And
okay.
one thing I would say, the other thing you can do is actually look at jugular distension.
I have a hard time with that in the CV unit because they always have a swan right there.
Yeah, yeah.
Don't tell me you can see JVD when you got a swan in your neck.
Exactly. Very good point.
You win.
Okay.
And that is something you should assess on the right side.
Mm-hmm.
Right. That's important. That's important to say that.
Yes. So that's
Remind me
something we
to
don't
talk.
use.
Remind me to talk about the air in the coronary when I get to my part.
Okay.
Go ahead. I'm sorry.
Okay. All right. I think that's the last part on the actual vascular vessels. So I'm going to go on to the heart. Okay. This is the Wiggers diagram. I'm sure everybody has seen this. It's going through, you have your lub-dub down here. That's just the sound of your valves. This is your EKG. Dang, my pen only works half the time now. That's the EKG showing you what part of the cardiac cycle these pressures and volumes are corresponding to. Your blue line is going to be your ventricular volume through the different phases. Your red line is your ventricular pressure. And right behind that, you see your atrial pressure. Okay? And then up at the top, you have your aortic pressure. These two pressures make a difference on when the valves open and close. Okay, so phase one, we're going to start right over here going into your atrial systole. Okay, this is when your AV valves are open. Your aortic and your pulmonic valves are closed. That's this phase right in here. You're represented by the P wave, starts it right here. Okay. And it's basically the depolarization of your atria. It's initiating contraction of your atrium. And as your pressure rises here in the ventricle, you see we'll get to that phase here, but you were passively filling here until you get the atrial kicks up an extra bit of volume into the ventricle here.
Which is why you lose 30% of your cardiac output when you're in atrial fib.
Absolutely. That's
Right.
because of that extra little kick of volume that you see in the atrial systolic phase, which is going to be our phase one. Okay. At this point, before your P wave, your ventricle is filled already with about 70 to 80% of the volume that they're going to have, with that remainder 25, 30% going to be added with your atrial kick, like Joe was saying. Okay. So then we go into phase two, which is our isovolumetric contraction. So all the valves are closed at this point. And the ventricle, marked by your QRS, has started contracting. So you can see with your red line here, your ventricular pressure shoots up very high, but there's no change in the volume. The volume stays the same because all the valves are still closed, which is why it's called isovolumetric contraction. Okay? And again, that's on the QRS of your EKG. Okay, phase three is going to be our rapid ejection phase, where your ventricular muscle raises the pressure in the ventricle to a point that is now greater than the pressure in the aorta, which is right here, and the pulmonic trunk, actually, if you want to consider them. This is more like the left side here that we're looking at, but if you're considering the right side, you're also increasing the pressure over your pulmonic trunk, and this is what pushes your aortic valve open. So right here is where your valve opens, and you can see the red line is slightly higher than your black dotted line, which is your aortic pressure, which is why the valve is open, because the pressure is greater inside the ventricle than in the aorta, and you get the rapid push of blood out, which is your hump here. At the same time, your blue line goes down because your volume is now leaving the ventricle. Okay. Okay, and then we go into phase four, which is going to be our reduced ejection. This is ventricular relaxation, and it's represented on your T wave here. And it's the pressure remaining in the ventricle begins to fall because the volume has now left the ventricle. Okay. It does hit this point right about here, where the pressure in the ventricle is now lower than the pressure in the aorta or the pulmonic trunk, and those valves close. Okay, which takes us to phase five, our isovolumetric relaxation phase, where you can see here the pressure dropping very quickly because the ventricular muscle is no longer contracting. But your volume down here is just a straight line through there. You're not actually changing any volume in this phase. You're just relaxing and dropping pressure. Okay. Right after that phase, your atrial pressure, right here by this black dotted line, once the ventricular pressure drops so far, now your atrial pressure is higher than your ventricular pressure, and that pushes open your mitral and tricuspid valves. And because the pressure in your atrium is slightly higher than in the ventricle, you get this rapid filling of blood just dumping back into the ventricle, which is what you see right here. And again, that will passively fill up to 70 to 80% of the volume in the ventricle. And then last phase is phase 7, which is the reduced filling right before the atrial contraction, where you kind of get a dip. The ventricle has accepted the volume and it hasn't had that atrial kick to expand it and take that last bit yet. Okay, that all makes sense?
To me,
Yeah?
it made perfectly good sense
Do you have
to
anything
me.
to add, Thomas?
Because
Right. Oh, of course.
this is in
So
Hushang Baluki's intra-aortic balloon pump textbook.
Oh yeah,
This
that would be
and,
right in here.
yep.
Your big, yep. So
This
it
is
looks
actually probably
complicated, but
This is the most important thing in the world of perfusion because it relates to filling pressures and fluid overload. And perfusionists are the one person that can overload a patient the fastest and cause congestive heart failure and by the patient in ECMO or a balloon pump. And I gave a great talk on this in PerfWeb 97, and so I'm not going to go over that, but go back and look at PerfWeb 97 and look at my talk on filling pressures. I called it "The Pressure is On," and that's where you're going to get the correlations of this chart to the world of perfusion. And before it's 9:30 and I have got to go because I have a procedure to do and I have to drive up there. But I want to say thank you, Joe and Vicki. Y'all, that was a great presentation so far.
Are you doing
I'll
the
be watching
heart?
on Yes. Yes.
Have fun.
Thank you, guys.
all right,
We'll
bye,
see y'all
Thomas.
next time.
Thanks, Thomas.
Bye. Thank you. Thank you all so much. And everybody, y'all, have a great day today. And hopefully you have a great rest of the week, which is only one day. Tomorrow's Friday. Yay. Bye.
Bye.
Yeah, so I think the Wiggers diagram is just, it makes
It
how
makes
the
so
heart
much sense.
functions
Yes.
makes sense to me.
Yes, me too.
So I think if you understand this really well, you understand fundamentally how the heart is working. Now, if you take this Wiggers diagram and you chart it out in a loop with your volume on the x-axis and your pressure on the y-axis, it is going to naturally form a loop because volume goes up as pressure goes down and so forth. It's going to make a loop. So it's exactly the same thing. So here's your mitral valve closing, your isovolumetric contraction. This is the volume here. So this straight line means no volume is changing. Your pressure is on this side, so pressure has gone up, but volume has not changed. Aortic valve opens and you get the rapid ejection phase. Aortic valve closes over here. Isovolumetric relaxation where your pressure drops, but your volume's not changing. And then back to your mitral valve opening. And you're gonna see with your volume side, in diastolic volume and in systolic volume. So the difference between those two will be your stroke volume. Your stroke volume represented here, basically. And all it is the difference between your in systolic volume and your in diastolic volume. Okay? It's kind of measuring load-independent parameters of contractility, meaning you can take these two parameters here and plot it according to the inotropy condition of the heart at the time. And you can measure hemodynamic changes in response to varying loading conditions and inotropic states. Okay, so the ESPVR is just the end systolic pressure volume relationship. And it is the relationship between pressure and volume in the ventricle when the myocardium reaches that maximum state of contraction near the end of systole, or the amount of pressure change given an amount of volume change when the myocardial muscles are fully contracted. Basically, this is just going to represent the inotropic state of your ventricle. Okay. This one down here is your end diastolic pressure volume relationship. And it's kind of telling us about our left ventricular compliance. So a decrease in compliance is indicated by an upward shift of your ED-PVR. And likewise, an increased compliance is represented by more downward shift of your ED-PVR. And so these lines give us our route, basically. So changes we make to this pressure volume loop will go up and down this ES-PVR and our ED-PVR, because those are telling us the inotropic state of our heart and the compliance of our heart, right? Systolic and our diastolic function, which is exactly where they're at on your pressure volume loop, your systolic side and your diastolic side. You need to know those things in order to know how the heart's going to react to different changes. Does that make sense?
Yeah, and can I add something to that? I don't
Please.
mean to interrupt you, but, because these pressure volume loops, although I am not a big fan of Abiomed as a company, I think the Impella has, appropriate utility when used in the appropriate circumstances, not just as a panacea. It solves every problem, but they were really big at creating these.
Yes.
And I do think they at least deserve some recognition for that a lot of their research led to our understanding of these pressure volume
Yes.
loops.
They brought cath lab data and information out of the cath lab to us.
Yes.
This is stuff they were doing in the cath lab, but we knew nothing about
Yes.
until Impella brought it out. I do agree with that. And I actually think I do, maybe I don't. I have it in other presentation.
Yeah, well, I'm very quick to criticize Abiomed as a company, but I think that when they deserve compliment, that I have to be objective and give them that due. I think they deserve that.
I agree. Okay, so with all of that information that I just gave you, and this is a very simplified pressure volume loop. There are many more applications and concepts that are incorporated in this loop, like workforce and things like that, that I'm not going to include for simplicity's sake. I feel like that would go beyond the course that we're doing here, and probably even beyond my understanding at some point. It gets far more complicated, but this is really all you need. Okay, so looking at, you see this line here, that's going to be this is good contractility up here, so that's good inotropic state, where this one down here is poor contractility. And it's basically showing you how much you're getting from your inotropic state. Normal is here in the middle, like our last slide. This one is more of a normal inotropic state with this ES-PVR up here. So they plot those and they make the changes accordingly. Okay, and this one I just wanted to show your diastolic pressure versus your systolic pressure is the tippy top of your loop, and then your end systolic pressure here. Okay. All right, so this is showing us changes in our pressure volume loop in response to changes that we are making. So this one, we have this inotropic state of the heart, and we are adding preload on the red. So you can see that one goes up higher where you have more pressure because you have more volume, but you also have an increased stroke volume. So this, you're getting an increase in your stroke volume with a positive response to fluid here. So this is showing us basically Frank Starling's curve. Okay. Decrease preload down here. You see we lose pressure because we lost volume, and our stroke volume is less. Okay. On the other side, this EA is afterload. That's all that one is. So on this inotropic state of the heart, an increased afterload, it increases the pressure because the heart has to push harder to open that valve. But because the afterload is higher, it's not able to eject as much blood. So an increased afterload results in a decreased stroke volume, whereas a decreased afterload results in an increased stroke volume. Does that make sense?
Absolutely.
All
I
right.
think looking at it here graphically helps to make it all make sense. These are excellent, excellent graphs.
I am a fan of the pressure volume loop. It makes good sense in my head. All right, so this one is a pressure volume loop of a patient being put on ECMO. So our baseline is here, and we have a bad slope here. So this is a patient with poor inotropic support. Remember, good would be much higher line. This is a poor inotropic. So we're looking at a patient in cardiogenic shock, okay? We add in 1 liter of flow on the ECMO, 2 liters of flow, and so forth, up to 4.75 liters of flow on the ECMO, resulting in such an increase in the afterload that our stroke volume is now this. Okay? Just kind of showing the probable need to vent your ventricle here. So that's what this pressure loop is showing. We're going up in pressure because we're not ejecting as much. This ventricle is going to start getting very dilated and need to be vented. At some point, when that aortic valve no longer opens anymore, it's just going to be a straight line. It's not even a loop anymore because no volume is moving. Okay. Okay, so this is just a refresher because we're going to go into the autonomic control of heart rate here. We have our main pacemaker here. That one is 60 to 90 beats. And your next is going to be your AV node here, 40 to 60 beats. Bundle a hiss, and you're getting down to 30 to 40 beats. Purkinje fibers down at the bottom. Now we're down to 20 to 40 beats. Those are your various pacemakers in the heart. Okay. All right, so autonomic control. This is, again, something you don't control. It happens automatic. And it is the component of the peripheral nervous system that controls cardiac muscle contraction. And here we're talking about the sympathetic again, increases the heart rate, just like it increased the vascular tone when we were talking about the vessels. It increases myocardial contraction, and then there's that vascular tone that we already covered. So we gave increased vascular tone to increase blood pressure, but we're in fight or flight, so we also increase our heart rate and our contractility to provide all that additional blood flow that we might need if we're running from a rabid dog. Okay. Parasympathetic slows down the heart rate with a limited effect on cardiac contractility, and it does this by releasing acetylcholine. Okay. Make sure I got everything there. And then again, the baroreceptor reflex, again, in response to acute changes in the blood pressure. It also does the same with heart rate. It will pick up those changes and reduce heart rate the same as it would with vasodilation and vasoconstriction. That slide is just in there twice. Okay. I think we covered this one already. I'm not sure why I have this one in here again. Of course, inotropy is going to be how strong the contraction is on your heart. Chronotropy is going to be how fast your heartbeat is. And dromotropy, that one is going to be how fast your conduction system can work. So kind of like an enhancement of conduction, I guess would be the best way to put that. Acetylcholine down here is your dominant neurotransmitter from your parasympathetic nervous system. And it has like your M2 and M3 receptors. M2 is in the heart, it's in your nodal and atrial tissue. And it's real sensitive to acetylcholine for slowing down or speeding up the heart rate. Also has some reduced contractility in your atrial myocardium. Your M3 is mainly in your vessels, and it kind of stimulates nitric oxide, your acetylcholine does. I think we covered norepinephrine already. So if M3 is in your vessels, that one's mostly going to be afterload effects, where M2 is heart rate. So heart rate's direct cardiac output effects. Okay, so changes to these aspects with ECMO. You want to do the last 4 slides?
No, ma'am. They're on you. They're on you.
So ECMO changes a lot of these physiological aspects that we just discussed in inflammatory ways, right? When it touches that extracorporeal circuit, it triggers all the inflammatory processes. You can get pulmonary congestion because of extra capillary leakage instead of the normal capillary beds, hypoxia, progressive development of epithelial and endothelial injury. I believe Joe talked about the glycocalyx yesterday. I think yesterday.
Yes,
so
it was
definitely what we're seeing
Or day before
there.
yesterday.
Day before yesterday. So the glycocalyx takes a lot of damage, and it plays a huge part in vascular permeability and interstitial collagen disposition. Okay. All right, and then of course the increase in LV end diastolic, left atrial and pulmonary capillary wedge pressures all come in response to that increased afterload to the left ventricle. Eventually will back up into the lungs, and you get that frank pulmonary edema. Peripheral vascular resistance can be decreased through baroreceptor response, pharmacologically with our vasodilators, or you can reduce it mechanically with like a balloon pump. You got to be careful with the pharmacological because you may end up using more O2 than you're able to supply. So not always the best option. You can reduce cardiac preload by restricting volume. You can also, which can also reduce your left ventricular end diastolic pressure and volume to some extent. VA ECMO will directly reduce the RV preload because we're physically removing blood from the right side and sending it to the arterial system. VV ECMO will decrease right ventricular afterload because it improves oxygenation and reduces hypercapnia or acidosis in the lungs, which decreases your pulmonary pressures.
So it's indirect.
Indirect versus direct here. Okay, and of course, if your heart recovers, then your map and everything will improve on its own, but otherwise you end up going to a vent, which we talked about just briefly with the Impella to fix that pressure volume loop problem when the valve quits opening.
Yeah, we had a patient back in the COVID days over at Luke's, and the patient was hemodynamically unstable. They were in cardiogenic shock, but the decision was made to put the patient on VV ECMO, although they were in at the moment left heart failure, biventricular failure. They were in heart failure, period. And
Is that a massive PE patient? I see.
no,
Okay.
it was COVID, and it was once we got the patient oxygenated, their LV function, their cardiac function overall improved dramatically, and so the reason for the heart failure was hypoxemia, or hypoxia, tissue
Yeah.
hypoxia or hypoxemia. That was the reason, and so because at first I was like, this doesn't make sense to me, and we did it, and the patient turned around very rapid as soon as they were oxygenated.
Sure. It was like a hypoxic suppression of cardiac function.
Yes, yes. The cardiogenic shock was secondary to hypoxemia. Yeah.
I feel like I see that to some degree in almost all our VB patients. You know, you're pretty immediately able to take them off of any pressors and so forth that they were on, even though they were probably requiring some pressors because of that
Yes.
hypoxic
Agreed.
kind of suppression.
Agreed.
Okay, so this is just a chart that kind of goes over some of the ventricular loads and coronary perfusion during VA ECMO. So RV preload in VA ECMO again is decreased. Direct drainage from the right atrium, cardiopulmonary bypass. We're literally removing it from the right side and sending it to the left side. Mobilization of physiologically reserved venous blood volume may happen by increasing overall cardiac output. Okay. Right ventricular afterload can be unpredictable. Multiple factors influence right ventricular, right RV afterload, such as pulmonary vasoconstriction, preload and afterload of the LV, vasopressors, ventilatory settings, and tidal volume status. So increased left ventricular afterload by VA ECMO may increase right ventricular afterload eventually, right? It can back up all the way back over there. However, improved myocardial perfusion by ECMO can also reduce RV afterload by improving the LV contraction, like Joe was just saying. Okay, LV preload is decreased because, again, we're not letting blood go through the native circulation because we're doing that cardiopulmonary bypass, reducing the pulmonary blood flow. Aortic regurgitation, even in a mild degree, can dramatically increase your LV afterload, and collateral circulation from the pulmonary system can vary, and the Thebesians can drain as well. LV afterload is increased because you have a continuous retrograde flow, which increases MAP but also increases the resistance. Reduction in MAP by the administration of vasodilators. If your vital signs can tolerate it, which usually they cannot, we usually manage that just by maintaining the lowest possible flow. Keep your MAP at 60, 65. You don't need a MAP of 90.
Well, I'm going to bringing that up. That's a good. I think that depends. I think that depends on what your body is adapted to.
As in like the kidneys kind of thing? Yeah, that's
Kidneys,
true.
brain, a lot of things. But I'm actually going to bring that up,
Okay,
and we can
Perfect.
we can delve deeper into that.
okay. And then, of course, coronary perfusion generally is increased because you have an increased MAP, and you're requiring less catecholamines, less pressors. If left ventricular diastolic pressure is too high by increased afterload, coronary perfusion may decrease. So a nice chart there. All right. And
I
then
don't think it may decrease. I think it does decrease.
I think it does too.
I don't think there's a may in it.
No may, huh?
I don't think so.
May not. This one is those pressure volume loops in response to a patient being put on ECMO. But this one shows your right ventricular volume and pressure. So here's your patient in cardiogenic shock, 2 liters, 3 liters, 4 liters. So you can see we are going down our pressure volume loop. And again, our our inotropic state is very suppressed instead of a good inotropic state. So cardiogenic shock patient, and we have dropped our CVP essentially, right? So that going down because we're not letting blood even going into the right ventricular system. But if we are taking that 2, 3, 4 liters from the right side, we are sending it to the left side. So now we're getting our 2, 3, and 4 liters here, increasing our pressure and volume on the left side with that retrograde flow. Okay. And that is my last slide.
So go back to your pressure volume previous slide. Yeah. So and that's two things. One is, it's clearly, and I think you said this early in your lecture, clearly an opportunity for venting, but it's also an opportunity to say, how much if I reduce the preload and don't overwhelm the amount of afterload, can I get this ventricle this left ventricle, without rocket fuel to eject? And so just because you went on ECMO and the predicted flow that you want is 5 liters, doesn't mean you actually have to flow those 5 liters. Patient needs 5 liters of flow, and they can give you 2, maybe being at 3 is a better place to be than going all the way up to 5, completely decompressing the left side, but making it so the right side, but making it so the left side cannot eject its contents.
Yes, I agree. And if you don't let any volume go through, sometimes you're causing the valve to not open because there's no volume to push out.
Right, that
so
too.
you've over drained the right side, I guess.
Yes, you have no preload on the left side
Correct.
at all in order to eject.
Exactly.
It may contract, but it doesn't have enough volume generator pressure to open the valve. That's a very good point.
I like it.
Yeah.
Yeah, you just really got to look at your patient and figure out what's going on, I guess.
Absolutely. Well, I got to tell you that in the for the week of work that we've done here for the PerfWeb 98 series, man, I can't wait until we do PerfWeb 100. It's going to be really something. I'm going to do something really big with that. But this has been, I think, my favorite lecture thus far.
Really?
Yeah, this was really, really, really good. This was very comprehensive. You had beautiful slides, explained everything extremely well. The slides were a great guide. I mean, you could almost have just looked at all the slides, but you added so much to it. But this was actually my favorite one.
Well, thank you.
Yeah, I was very happy. Okay, any questions from our audience? Let me make sure. Do you have anything on the face space or the Instagrams? No, nobody wants to answer. Ahmad, any questions? Jeremy, Lori, Derek, Kelvin, Carly. Carly's a Canadian, I believe. What was the name of the person that we sent that cup to that they never got, and I resent it? Do you remember? Yeah, look and see, because I'm curious to see if they're here. Well, anyway, but that was, listen, all I can tell you is that was excellent. Thank you very much.
Thank you.
I appreciate you.
I finished on time too.
You did. I mean,
I was worried I'd go over.
even with all of the interruptions, and you had a lot of interruptions. And no, this was really great. Okay. How do you want me to do this, David? Do you want me to just do it on my computer, or do you want me to try to share my lecture over to share it to the iPad? Let me see if we can. So let's close that. Do you want to keep or no?
Discard.
Discard the
My
annotations.
scribbles.
Okay, and then share AirDrop to the iPad. It should pop up. There it goes. Done. Then we'll open it. Okay, and then we'll go to presenter view. there.
There
Okay,
it is.
so it worked. All right, very good. So let's just go ahead and jump into mine. Mine is short, and it's just intended to be fun, really, at the end of the day. So measuring perfusion adequacy. That's good. I can get
Okay.
right here. What does a perfusionist do? We might have to replace this tip because it looks like it's almost getting worn out.
It does look
You
like
see
it's
that?
getting kind of,
Can we get a new pen for this iPad?
that might be why it wasn't working very good for me.
I think so. Yeah. We can get a new pen. So perfusion, what does a perfusionist actually do? And I had gone at one point in time to various places. I went into restaurants with a camera and asked people, if they knew what a perfusionist was. I even set a booth up in the mall where you could win $1 if you could answer the
Oh,
question,
man.
and people would come in.
Nobody got it, did they?
And man, I'll tell you what, some of the answers were really impressive. I can't even say some of the things that I was told. And I actually went to Memorial Hermann, the Maine, in the medical center, and they sent security up there and law enforcement to ask me who the hell I was and what the hell I was doing, because I had a camera set up and was asking people. And people in lab coats who didn't know what the hell a perfusionist was. It was just absolutely amazing. I thought it was quite comical, actually. But here we are, at the post-day dinner party, because we always finish our cases right around happy hour. And they're real excited. This guy right here, he kept the pressure at 50 the whole case. There were no complaints from anybody. It was just fantastic. So is that perfusion adequacy? I don't know, but we find all kinds of reasons to be excited.
Which one's anesthesia?
No, it's just a group of perfusionists. These are all just perfusionists.
Gotcha.
Yeah. I kept the bed 50 the whole case. Yeah. So, and then of course, so you get the inevitable. So what do you do for work? And I'm a perfusionist. Oh, what's that? And the answer is, I maintain the patient's normal physiology during open heart surgery with the use of the cardiopulmonary bypass system or machine, whichever you prefer. And everybody is always so impressed. Ooh, that sounds like a serious job. I mean, if only you would actually want to go to work once in a while, it'd be nice too, but that's a different problem. All right. That's a different issue. We love talking about what we do, but we don't love doing what we do at inconvenient hours, which is frequently when we have to do what we have to do or what we're supposed to do in the most important moments, not that elective out by noon with no balloon, single
2
vessel
a.m.
lima, right?
code.
Or something, 5 o'clock in the afternoon, your kid's birthday, your anniversary, the day before your vacation when you thought you were going to be off and you could pack and everything, and now you have to work. The list goes on and on and on and on and on. But anyway, I'm not sure of the two people you see here, which one is the perfusionist and which one is the impressed one. I'll leave that to your all's, just the way you want to view it. But it could go either way. Okay. But what do we really do? Okay. That's, I think, the fundamental question here. Well, we take away pulsatility, natural pulsatility, physiologic pulsatility entirely and very, very acutely, which, all new artificial heart devices, TAHs, total artificial hearts, are continuous flow pumps. So you will adapt to that, but I'm not sure what the effect of just acutely taking away your pulsatility has on the overall body's physiology. I would think it would have,
No
it would
compensation
do
time.
something, right?
Hmm.
Or we use a pump generated pulse, which is, not physiologic by any stretch of the imagination. And I'm sorry. We're competing. We're having competing mics. I'm so sorry. Thank you.
I wasn't using mine.
That's okay. Or we pretend we generate a pulse with this, pump generated pulse. But at what cost do we do that? We talked about the harm the extracorporeal circuit does, whether it's ECLS or whether it's for ECMO or whether it's full cardiopulmonary bypass. But, we have very hostile pressures. And now you're going to try to generate this pulse. And I've measured it. I gave a lecture on it, as a matter of fact, within the system. And you have pressures that range when you're trying to pulse with this mechanical made pulse and the centrifugal pump of around 40 millimeters in the arterial line I'm talking about, all the way up to well over 400. It was unreadable. It went above the level of what the machine's ability to read. So it was above 400. And that's very, very high. So what does that do when the blood is jetting through the arterial cannula at those kinds of pressures, or in the system with all the various different twists and turns that we have? I'm not sure that's really a good thing to do. I don't think we always have to have the risk-benefit paradigm scale that we have to sort of take into consideration. What's the risk of what I'm doing for what benefit? And that should be higher risk or higher benefit for lower risk, as opposed to really high risk for very questionable benefit. I think when you're in that paradigm, you probably shouldn't do it. That's my belief. We have hypotension for extended periods of time. I'm not going to go through the formula and waste y'all's time, but let's just say a normal, healthy person, which none of our patients are. Our patients are not healthy, but normal blood pressure for a 50-year-old is, if they were healthy, 120/80. Would you agree that's a nice blood pressure?
Yeah.
That's a mean pressure of somewhere between 93 to 95. That is the actually, that's not the right symbol. I apologize for that. Thank you for noticing that. Go back and do that again. That's more appropriate, right? Mm-hmm. Does that mean? That's mean. That's how you draw mean. Mm-hmm. Yeah, thanks. Is between 93 and 95. So we run pressures anywhere between 40 to 60, pretty routinely mean pressures. Maybe we do 70, 75, but so many times during the procedure, we have very, very, very low pressures. You saw my picture earlier. I kept the pressure at 50. That's where he wanted it the whole time. People can get through that, but there's going to be those patients that's, I think, going to harm. And I don't think every patient should have a mean pressure of 80. I think that you have to treat each patient as an individual, as opposed to having a protocol that this is how we do our cases, whether that be with flow, whether that be with pressure. Doesn't make any difference. I think that we do not do a good job in that regard.
Yeah, what they're used to. I see what you're saying.
We have acute and severe hemodilution. Hematocrit goes from 33, 35 to 23 to 24, maybe 21, very commonly, which is a very rapid hemodilution. And obviously anemia, less DO2 given a particular cardiac output. We cause acute severe hypovolemic shock syndrome. We open a line up that's stuck in the right atrium at inferior vena cava under vacuum, low vacuum, minus 40 or so, but we completely suck the right atrium and right ventricle flaccid. It just goes to zero. Well, what is going to happen with our receptors in our atrium when it sees that? They're going to say, what the hell just happened here?
The hell?
Right. We have significantly reduced DO2 than is normal, albeit the patient's asleep and paralyzed and cooler and all of those things. I mean, those things do mitigate that, but we do have significantly reduced DO2. And we see that, if you were to measure lactates on cardiopulmonary bypass, you tend to see lactate levels climb a little bit. You see your base deficit get a little bit more negative over time. Not always, but not infrequently either. We have to generate higher line pressures to accommodate the higher flow because our restriction point is the arterial cannula, which isn't going to be any bigger than 24 French, and really 21 French is probably more realistic. So a normal aorta is 2.5 centimeters, the ascending aorta, and we're putting it through something that's 7 millimeters. The same flow. That's a big difference in size. We expose the blood to a very large foreign surface area over and over again for a couple of hours or an hour or so for a heart surgery, days, weeks, months on ECMO, and then changing the circuit and all of that. We have the blood-air interface, and we see this, by the way, by this frequent need for pressors. That inflammatory reaction happens. So you have severe hypovolemic shock, receptors responding to that, inflammatory mediators going crazy, causing an opposite reaction to vasoconstriction, vasodilatation. You just never know where. You lose your pulsatility and you go to continuous flow. You're changing the patient's hemoglobin and viscosity by tremendous amounts, and you might be cooling them all at the same time. So all of this happens in a very brief period of time. So what does the physiology of the patient, how does it manage that to where it even has a clue what it's doing? I imagine it's just sensory overload for the normal physio. If you really think about what we do and how that is going to be managed by our, we tolerate it because it's just hard to kill people. I mean, if it wasn't as hard to kill people, we'd be killing people all day, right? We expose the blood to hostile pressure environments. I've already said that. Blood-air interface would create that. And we introduce air everywhere. There's air is everywhere. You can't do an aortic valve or a mitral valve or a coronary, for that matter, and not have air everywhere. You've got the pump suckers. There's a big blood-air interface. You have an open reservoir. There's a blood-air interface. You use the Mr. Blower, which is blowing CO2, albeit directly into the coronaries. And sometimes that is able to go right up the coronary because you're on bypass. The clamp is on. There's no pressure in the aorta, and you're pushing that up there. And even if the clamp is off and you're doing an off-pump cabbage, that pressure can be higher than the aortic pressure, especially in diastole, maybe not in systole, and that CO2 can go right up out of the main coronary artery, the coronary ostia in the aorta, and go everywhere. You do a valve, you can never de-air the heart completely. There's air everywhere. The heart-lung machine generates GME. There's gaseous microemboli everywhere. Those are realities. So what do I really do? Somebody asks me who is, a clinician like me, or somebody who maybe is an engineer. It's hard to explain what I do to somebody who has no medical knowledge at all or science background at all. But by and large, what do I feel I do? I mitigate to the best of my ability the harm I know I am going to cause. That fundamentally is what I do every day that I go to work. That was my last slide. What say you?
Very good.
What's your thoughts on that? We have 5 minutes.
I think that's accurate. I mean, you're doing a lot of damage. Never really thought about it that way, but yeah.
Mm-hmm. Yes.
Are you going to start saying that?
I've been saying that.
You've been saying that?
I've been saying that for a long time. People ask me what I do, that's, you know, that, I mean, if somebody asks me, oh, what do you do? What's a perfusion? What is a perfusionist? We operate we operate the cardiopulmonary bypass system during open heart surgery, or more commonly referred to as the heart-lung machine, whatever. But, you know, if I'm talking to a set of colleagues like I am here with you, for me to say I maintain the patient's normal physiology throughout the operation is bullshit. I don't do that. There's nothing physiologic about what I do. I just mitigate the harm that I'm going to cause. And I think if we thought of it more like that, maybe we could, because the advancements in perfusion and even ECMO tend to be steep and plateau. And perfusion has been on a plateau for quite some time. I think we could get a lot better, but I think we have to change fundamentally how we view what we do.
I like it.
Okay,
So true.
this is the end of PerfWeb 98. Today, in my opinion, was the best. Notwithstanding, we love Dr. Patel, but that was tough to go through all of those x-rays and imaging and stuff. That's a hard lecture to give, especially to people like us who are historically not really looking at images. But, you know, when I'm in the OR and they're doing we're looking at the TEE before surgery, you know, I'm always looking over there. I want to see for myself that there's no mitral regurg. It gives me a sense of confidence. We're just here to do some coronaries and I'm going to get out of here. I want to know how much AI there is, if there is a lot of AI, because that's going to tell me I don't want to fibrillate this heart before that cross clamp goes on, if I can avoid it, and my antegrade cardioplegia may not be very effective. Tells me that in advance. I'm in the ICU and I want to know, how's this patient doing? Are we at a point where we can wean? Looking at the daily chest x-ray, what am I looking at? You know, you might see a pneumothorax beginning before anybody else does, and bring it up, because we're there at the bedside when they're taking all these x-rays. There's a lot of things we can do to just be a part of the overall team. It doesn't mean we're going to be that radiologist or we're going to make any decisions, but I just have to say that I think the more you know, the better. The more you know about everything, the better you'll be at what you're supposed to do.
Well, I think it's important to know how to see certain acute things happening, especially on your chest x-ray, because they come by at 3, 4 in the morning and there may be a pneumo there that you see because you looked at the actual machine, but it could be hours before the radiologist reads it or the doctor sees it. You may be the first person to see it, and you can notify people and get things in action before that pneumo becomes critical.
Exactly. Very good point. Yes.
I think
Making
it's
you
important.
part of the
Yes.
team. Right. Exactly. And, or being able to question something and say, you know, hey, you know, let's say you're doing a heart, you know, and you see AI on the thing, you know, it may be worth saying to the surgeon you're working with, are you going to put a retrograde in? No, why? Well, there's a little more AI than I think you might have an issue. Let them look at it themselves and make that decision. But then you're given the cardioplegia, they're looking for the LV starting to distend, and they're like, I should have done retrograde. They could still have time then to get a retrograde in.
Perfect.
So, you know, I think that it's worth being interested in things, not for being pompous and knowing everything, because you just can't, but just makes you, I think, a more valued and invaluable part of any overall heart care or critical care patient team.
Yes.
Okay. Our next program currently is scheduled for June, and that is the didactic portion of the ECMO specialist course. This is very different than the way we do this. You absolutely have to be there live. It's 20 CEU through the ABCP for the 2 days of didactic, June 27th, 28th. It's online. You'll be able to sign up for it today. If you just want the credits and the knowledge, you pay at one price through RegFox. You'll see that when you do the registration. If you are an unlimited member of Perfusion Education, then that is included in your unlimited plan, but you are still going to have to go to the RegFox and register. It'll have a section that you click it, I am an unlimited member of the, and paid, unlimited member of PerfWeb or Perfusion Education, and then that registration fee for it will be zero. But we absolutely need to know who is registered, because the board, again, was very strict, becoming stricter, which I could understand why, and we're going to have to take some real measures to make sure everyone is there for the whatever duration of time it is that they claim the appropriate amount of credit. We don't want to be the CEU police, but I do want to work with the board in a positive way so that they can accomplish their goal as well, and that's to make sure that people are actually attending these courses. I mean, I think I understand it, and I want to make sure that I'm a part of that good partnership with the American board, because they do help us quite a bit. If you want to do the full course and you want to do the simulation as well, that is separate, so it's a separate course you would have to take. I do think if you're an unlimited member, there's probably an opportunity for some discount there. If that's what you think you want to do, take a look at it. Reach out to me and I'll see what I can do as far as giving you a discount if you're already an unlimited member for the didactic, that you're just going to pay for the simulation portion of it. Yeah. I think that would be reasonable. Right now, I don't have that built in, but we can do that. You just need to let me know you want to do the full course. The course only takes 16 people. And that's because of the simulation. We want to make sure everybody gets a chance to touch everything. So you have to, if you are going to do it, you better register early. It fills up quickly and you don't want to be left in the cold. But total, it's 40 credits. So it's almost your entire 3 years worth. You could do that one course and then one PerfWeb and have 45 credits for your 3 years, just like that. So pretty good, and 25 of those credits would all be virtual, but you have to be there for the physical simulation portion of it. Okay. I can't think of anything else that I need to say about that. We will be doing another PerfWeb, so I think the ECMO course is going to end up being PerfWeb 100. Okay. And for us, okay. Right? Not for you, not for the nurses. They won't know that. Okay. So it won't be, it'll be 2 tracks happening at the same time, if that makes sense. Gotcha. Because I want something special for the 100th, or it may not be. I might just not do it that way, but we'll have 99 up pretty soon. Probably this is March, April, probably going to be early May, late April or early May for the next PerfWeb, and I'll get that up in the next few days. So I appreciate everybody's efforts. It was great seeing everybody. Thank you for your participation today. And we keep an eye on the website, keep an eye on your email, and we will see you next time. Peace out.
All right, bye.